My pleasure to introduce next speaker is Professor Ayman elsamadony. He will talk about the hybrid iliofemoral venous occlusion, the value of endophlebectomy.
Bismillah ar-Rahim. Thank you, Mr. Chairman, and thanks for the board of EVC and the Venous Delta Group for inviting me. Just go through of course, we know that deep venous occlusion is either by internal causes or external causes, and external causes act as a permissive that allows for the occlusion later on to occur. About 40% are precursor in the occlusion is the non-thrombotic iliac vein lesions that Khairi already exploited. It presents representative conditions, and only 20-30% of iliac vein showed complete recanalization. 44 and 15% with either venous calcification or stasis ulcer within 5 to 10 years of the incidence. Of course, we know the conservative compression, anticoagulation, and then followed by antiplatelets, but which is still the mainstay therapy. The endovenous BTA alone is obsolete, and BTA and stenting are advisable. The bypass is a femoral crossover, like Balmer procedure or synthetic femorocaval bypass. And hybrid is to improve the inflow vessel to the ILIACs that includes endophlebectomy plus or minus arteriovenous fistula. The requirements for stent per segment is that the inferior vena cava should have a high radial force, minimal flexibility, and large diameter, while common iliac veins having a high radial force, high flexibility, and long lengths of the stent, together with external iliac and the common femoral artery, it should be somewhat a fracture resistance. But in all, an adequate inflow vessel should exist, either the profunda femoris, which is the mainstay, plus or minus the femoral vein. The shortcomings of the stents either to have a compression, if we are using low radial force stents, or kinking of the stent, or tapering of the stent, which is common for all stents, and the fracture of the stent, especially crossing the groin, and bamboo-like, stick-like effect. According to CERSI standard practice guidelines on iliocavernous stenting, that the only patient with CERS 3 to 6 will have an endovenous circulation and stenting, and those who having insufficient response if CEEP 0 to 2. However, the same guidelines show that stenting across the inguinal ligament should be avoided, and if the poor venous inflow and endophlebectomy plus or minus arteriovenous fistula should be performed. The idea is to get yourself away from crossing the groin with the stent, and then but also to increase the inflow to the stent either through the greater saphenous, femoral vein, and profunda femoris vein. My case, a female patient, 29 years old, with 18 months history of pregnancy-related iliofemoral DVT, treated conservatively in the beginning, presented with disabling edema and venous claudication as part of conservative treatment for 18 months. Duplex and CT venography were ordered, and it showed non-ossification of the common femoral vein and attenuated iliac veins. So planning, following the CERSI guidelines, hybrid procedure involving open carotid common femoral endophlebectomy and iliac vein PTA and stenting. Why not stenting alone? Because it's selection of either, it leads to selection of either from, as the condition just Professor Mahdawi just said, you have to go from normal to normal. So it's either going to select either the femoral vein, if you are using the popliteal or distal femoral vein axis, or the profunda if you are using the jugular axis, and that means we'll have a fibrous core shift with occlusion of either or both the femoral vein and deep profunda femoris vein, and avoidance of stents crossing the groin. Under GA in the angiography suit, the left groin was explored, and exclusion of the common femoral vein with control of the greater saphenous, femoral vein, and deep femoral veins. And that is how it showed this fibrous core here inside. You encircle it with blunt hemostates all through, and then after you finish this procedure, you pass your wire as next. If you are cutting the fibrous core without passing the wire, the fibrous core will get crumbled in the iliac veins and will not give you an access to the cave. And then we complete our endophlebectomy. As you can see here, all mouths of the profunda, greater saphenous vein are all open. I'm sorry, the quality of the picture is not that good. And this, our wire is passing through into the inferior vena cava, parking higher up in the inferior vena cava. And we used one of the great surface tributaries as a vein patch for closure. And then we close almost all the vein patch, leaving a small window for introducing of our introducer sheaths later on. And that is the ILIAC stenting. That's the initial angiogram. We use the RM caster to identify where our iliac is, as not to cross it. And then the ballooning. And further ballooning, I'm just cutting the story short. And then there's the first stent. We used 18 proximal and 16 distal. And then, as you can see, appreciate here, that's this iliac still stenosed, and that's why the collaterals are still filling. And then we put second stent and then ballooning. That's a distal ballooning just within the vein patch. Actually 1 or 2 centimeter, only 1 centimeter of the stents will get beyond the higher end of, or the proximal end of our patch. And that's the follow-up. So that's how it ends. And the patient had a follow-up duplex. As you can see here, the patency of the stented segment of the iliac veins, and with a good flow, and there is no synechia present within the vein. So our take-home message that endophlebectomy is feasible and safe procedure. It does not increase the chance, it does increase the chance of the stent survival. Wire lesion should be crossing and should be attempted before the fibrous core excision. Suture vein patch over the sheath to allow inflow from the iliac vein, from the profunda femoris and the femoral vein into the iliac vein during stenting. Compression and anticoagulation should be maintained for 6 months post-operative. Thank you very much.